Welcome to the CMH Family Medicine tutorial. We are focusing on deep vein thrombosis and pulmonary embolism. This is part 5, where we're going to be focusing on how you adjust your warfarin dosing and looking at the ins and outs of managing a patient on taking warfarin over several months or maybe even years. Thank you to Dr. Ashraf Mohammed that's helped us with compiling these slides. So there's a few important things to remember when you've now prescribed your patient warfarin and following up your patient with warfarin. Very important, it's contraindicated in pregnant women, and you have to keep this in mind if you're going to prescribe it to anybody who might be in their fertile years, and making sure that they're properly covered with contraception. If your patient is going to go for a surgical procedure, you need to think ahead a little bit. So they've got an elective surgery planned. You may want to stop that warfarin, and you need to make sure that the INR is 1.5 prior to having that surgery. We also want to explain to our patients when to recognize the signs of warfarin toxicity, which basically means the INR is too high and they might start bleeding. And the typical place that they might bleed from is either from the nose or the gums. And to explain to them if they've bled more than 5 to 10 minutes while they're applying pressure to those areas, that they must urgently come into hospital. There's also the interesting thing that there are some influences of food on managing your INR, and this is a little bit more tricky to teach our patients. The one thing to consider is that there are foods in with vitamin K. So the problem is not to tell our patients they can't consume foods with vitamin K, but if they do have favorite foods that has vitamin K in it, it's foods that they must be eating regularly. So the challenge is if they've got a particular event and they eat a whole lot of broccoli and they don't normally eat broccoli, that can potentially interfere with their INR because their warfarin might not have taken that into account. So there's a little bit just to be aware of a fairly steady diet and just to be aware of which foods you can't suddenly go on and binge on. But there are also actually foods that interact with warfarin. For example, the absorption of warfarin, and these are foods that best be avoided. In our population, you can see these are more your higher socioeconomic groups that might have things like grapefruit juice and cranberry juice, but particularly alcohol is potentially an issue. And so we would not want our patients to be taking a lot of alcohol during the time that they are on warfarin. It's also useful to understand that there are patients who might be more at risk for bleeding on anticoagulation therapy. These in themselves are not contraindications to give warfarin. It's absolutely important to manage our patients, but we want to perhaps watch these patients a bit more carefully. So, for example, our older patients, patients with uncontrolled hypertension, patients who've got a history of gastrointestinal hemorrhage, or, for example, an active ulcer, patients who are known to have challenges with coagulation already, if there are a history of stroke or cognitive or psychological impairment, poor kidneys, recent trauma, and again, the alcohol intake here is also potentially problematic. And we need to be a little bit clear of what other medication can be problematic, especially, for example, our aspirins and our NSAIDs. So the trick with adjusting warfarin, and I'm always surprised that this is not always as widely known as one would like it to be. And quite often when we're adjusting warfarin, it's a bit of a thumbsuck, but there's actually a very nice structured way and how you decide how much you're going to increase this dose. So this is also from the EML. If you go into EMG guidance and you look up warfarin specifically, it has these tables in your EMG. So you'll see here that this is now for when you're monitoring your warfarin for a patient who's already been initiated, has already been stable on warfarin, and now they've come back for a routine INR check. And you can see there if the INR is, for example, less than 1.5, you can increase that weekly dose by 10%. If it's between 1.5 and 1.9, increase the weekly dose by 5%, and between 2 and 3, you don't need to worry very much. And then again, there are very specific guidance on what you do when the INR is over 3, over 4, or over 5. I'll talk a little bit specifically over 5 as well, because those are our patients who are at much higher risk. And so we would have to decide whether we're actually going to give these patients some vitamin K. As you can see, what we are doing to make our decision on how much we're going to change it by is using the total weekly dose. And that's the most important thing to realize. You don't need to know just how much your patient's taking per day. You want to think in terms of that weekly amount. There's also some recommendations that if you are very close to 2 or just over 3, to also not get too vigorous about changing dosing too quickly, you might want to check another INR just to make sure that you are actually definitely abnormal. So let's just look at how we do this weekly dose calculation. So I'm going to give you an example here of a patient, for example, who's taking 5 milligrams every day, and therefore their total weekly dose for the 7 days is 35 milligrams per week. If they have a 5% change, as recommended by that table, that'll be plus minus 1.75 milligrams, and a 10% change will be plus or minus 3.5 milligrams. So if my patient comes in and they've got an INR of 1.3, and we look at the table and it says you need to add 10%, for a 10% increase in that patient, then you're going to add 3.5 milligrams. So that gives you a 38.5 milligrams total weekly dose. So now to decide how many tablets you want to give in a week, I usually divide that number by 5 milligrams because that's the size of our tablets, which comes to 7.7. So if you round that down a little bit, that would be 7.5 tablets per week. So she's been having 7 tablets a week, and we're now going to go up to 7.5 tablets per week. So you can look at an easy way to do this. For example, with her, we can say, great, now you're going to take your 5 milligrams every day and then 7.5 milligrams on a Sunday. So depending on we have this 2.5 milligrams that we can use. You can split the tablet in half. And so sometimes you might, to be able to get to that particular dose that you want to give, you might have to have alternate dosing, for example, 5 and 7.5 alternate days or whatever. So depending on what your total weekly dose is. The weekend plan works quite nicely. So say, for example, she needed to take 8 tablets a day. Then what you might do is have 5 milligrams per day from Monday to Friday, and then to have the 1.5 tablet on a Saturday and 1.5 tablet on a Sunday, which will then give you those 8 tablets a week. And just remember, we are working with 5 milligram sized tablets. So how frequently are we going to check that dosing? So you're going to check that INR every 3 to 5 days, and if you're busy starting or stopping an interacting medication, for example, if you've got a change in diet, activity level, anything else that you're making you worried about that INR, you're going to want to check it quite often. Otherwise, if you're busy dosing and adjusting, you will check it 1 or 2 weeks later to make sure that you are on track. And then once you're on track, you can look after it. You can do it every 4 weeks in that first 6 months. And if for some reason they have to take it for more than 6 months and they're very nice and stable on that dose, then you can potentially get away with doing your INR every 6 to 8 weeks. So as I said, I did mention what do we need to think about when that INR is very high. So if the INR is over 5, you're going to stop that warfarin dosing for a couple of days at least. And on the table, there's recommendations on how much you will adjust the dosing when you restart. But you have to decide how much my patient is at risk of bleeding. And so remember, we talked about those possible high-risk patients, also stroke patients, for example, patients with renal failure, patients with anemia or with hypertension. And in those patients, we can give them some vitamin K, 1 to 2.5 milligrams for a couple of days, and then we're going to monitor that INR again. If they're a low-risk patient, so there's nothing else that makes us concerned, and they don't have any active bleeding, then you can actually get away with stopping your warfarin and monitoring that INR. If the INR is over 9 and they're not bleeding, you're also going to obviously stop your warfarin, but all of those patients, you would definitely give some vitamin K, slightly higher dosages, 2.5 to 5 milligrams, again for a couple of days, and keep an eye on that INR. And once they are stable, then you're going to resume the warfarin therapy at those adjusted dosing as per that table. It's interesting to note that the vitamin K1 is usually just available as a parenteral preparation. So we only get it as an IVI preparation, but there's now very good evidence that you can very safely give it as an oral preparation, specifically in anticoagulant poisoning. So in these scenarios, we can actually give that vitamin K as an oral preparation, even though it comes in an ampule. In those patients with significant bleeding, you will definitely be admitting those patients, but the way we management is going to be largely through giving them fresh frozen plasma or lyophilized plasma developed depending on what you have. Just in terms of when we're finally going to stop our warfarin, it depends a little bit on what caused the warfarin in the first place. So usually the recommendation in the EML is 3 months if the DVT was provoked. So for example, they had a DVT after they had an operation, or they had a DVT while they had TB. Now it's 3 months later, it's the operation obviously has passed, or the TB has been treated, and then the 3 months of warfarin is more than adequate. If it wasn't very clear what caused that DVT, then it's safer just to cover them with 6 months. And then there are patients where you're going to consider giving lifelong treatment. For example, if there's a recurrent DVT, or if they've got some genetic clotting defects, for example. There are also tables that think in terms of transient risk factors and persistent risk factors, and this might be also useful in terms of making your decision. So your transient risk factors would be a bit what we would call those provoked DVTs. So for example, people who had surgery or cesarean section, who'd been on estrogen therapy, which had now been stopped, or had been pregnant, or had had a leg injury, for example. So all of those 3 months will be quite adequate. But if you've got ongoing risk factors such as active cancer or inflammatory bowel disease, chronic infections, chronic immobility, then you will also be giving longer courses, either 6 months or even potentially lifelong where needed. And those you can discuss with the specialist who is looking after that patient. Our next is just going to be focusing on which of those patients we actually want to give prevention of patients who might be at risk of getting a DVT or a pulmonary embolism.